Hello, and welcome to CQC Connect, the podcast from the Care Quality Commission. My name is David Gwyther, and I'm a Communications and Engagement Manager here at the CQC. Today, we are going to be looking at the CQC's Regulators Pioneer Fund project, which is looking at reducing health inequalities in areas of deprivation through better regulatory recognition and the sharing of best practice, with funding from the Department for Business, Energy and Industrial Strategy. I am joined by Dr. Devina Maru, who is a National Medical Director's Clinical Fellow here at CQC and Project Lead, along with Annabelle Stigwood, a CQC Primary Medical Services Inspector. We are also joined today by Dr. Farzana Hussain, who is a GP at the Project Surgery in Newham, East London, and Clinical Director for Newham Central 1 Primary Care Network, and who was also GP of the Year in 2019. Devina, if we can start with you, how did this project come about, and why is it important to the CQC?
Thanks, David. So we know this COVID-19 pandemic has had a huge impact on health and social care. And it's really exposed a lot of health inequalities faced both by people who use the services and also people who provide the care. And we felt that the CQC, as the regulator of health services, should encourage improvement and innovation in this area. And it's also one of CQC's new core ambitions as part of their strategy, which has an emphasis on reducing inequalities and promoting innovation. So the CQC hopes to continually foster a supportive regulatory environment for services where they feel able to try new approaches to care that reduce inequalities. And that's why it's really exciting to receive this grant by the government to explore the innovative ways that GPs in England have tackled health inequalities.
Annabelle, what exactly do we mean by innovation, and how can this help to tackle health inequality?
Do you know, David, that's such an interesting question, because I think sometimes there's a bit of confusion about what innovation actually is and what this means in a GP practice. And sometimes there's a misconception that an intervention or approach is only innovative if something new is invented or implemented. And whilst that might be the case, it doesn't have to be. The innovation can be improving an existing system or practice and refining it to better respond to the health inequalities and meet the needs of the patients. So we know that health inequalities are avoidable, they're unfair, and that they're systematic differences in health between different groups of people. They're not random and they can be avoided. We know that the causes of health inequalities are vast and complex, and these can include factors such as poverty, discrimination, and they can be motivated by economic or educational reasons, for example. The effects can be seen, they're massively concerning. They can be seen on people's well-being, their healthy life expectancy, their morbidity and mortality. So in the fieldwork that's already been undertaken as part of this project, we've heard of some great examples of innovation in tackling health inequalities. We've heard of practices who've worked with existing very good patient management systems, but found a way to improve them to better meet the needs of their patients who are experiencing health inequalities. And in this example, what we found is that they've gone the extra mile to make to their learning, to make not only just real improvements for their own practice, but to go back to the management system so that other populations can benefit too. And that's a really innovative approach. But similarly, we understand that practice populations are unique and not all innovations can be rolled out to other practices. That just simply doesn't work. We don't underestimate the importance of adapting innovation to the local context and getting that implementation right. That way, innovation can make a real difference in tackling health inequalities.
Thank you, Annabelle. Farzana, why is innovation and recognition of innovation important to general practice?
So I think it's following on from Annabelle's point, isn't it, about what is innovation, and does innovation always have to be something new? The reason that it's important, David, and if I give you a personal example, I work in an area in East London that it is highly deprived, and sadly we had the highest COVID death rate in the country in the first wave, and COVID has just really uncovered health inequalities. It's shone a light on them. It's not that health inequalities weren't there before, but it's great to see that it's really on everybody's mind now, so we can change it, because as Annabelle says, this is avoidable. So if we think about general practice, so we're all trying to achieve similar things, but we're all starting from different baselines. So if I take an example of cancer, so for example, general practice is very involved with screening for cervical cancer. It's the 6th most common cancer around, but sadly it doesn't have any symptoms with it. So the screening is very, very important to save the lives of some very young women. We know that under 35s tend not to come for their screening that much. So I have a friend who works in Loughton, which is only 5 miles down the road from me, and his only difficulty in achieving 99% is that some of his lady patients go and have it done privately, and they don't give him the results. I, on the other hand, to reach 76%, and when the target is 80%, really had to think differently. We were stuck at about 50% for a number of years. So with the innovation wasn't anything dramatic. It was really thinking about, why is it our patients are not coming? How do we tackle that? Do we have the workforce then to actually encourage these people to come more? Because we know they're not going to come with one text message, they're not going to come with one invitation. So something that we did at our practice, I run a list of 5,000 patients, is that we really did use that cliche of making every contact count. So if a patient came in for their sore throat, it was like, oh, shall we just do your smear for you? So in order for that to happen, we needed to ensure that the nurse had some spare appointments every day. In order for that to happen, we needed to ensure that everybody in the practice, every single member of my team of 10, from receptionist to healthcare assistant, knew that if somebody was coming in, they would look to see if they needed a smear, and then they would be able to have that sensitive conversation to encourage them to have it there and then. So these things, each part of that is not particularly innovative. You would think of that as good clinical care, but piecing it all together and actually achieving those results is very innovative, and it's something that I'm really pleased to say our practice was commended for by CQC, because in an area where we have very low uptake rates for cervical cytology, never more important now, because in the first wave of COVID, London had a pause for 6 months on cytology, so we have a lot of people who need those tests. So that's a small example of things that may sound obvious, but actually doing them together as a team, so we're all working together to achieve a shared aim, and keeping at it as well, and ensuring that we do it with the sensitivity for our patients. It's quite frightening for a woman to come in for example, a chest examination, and someone to say, well, do your smear for you now, when she's actually quite scared about it, and there may be lots of reasons she may feel embarrassed about it. So put together, I think that is an example of innovation, which perhaps isn't always recognised. We think of innovation as the big shiny things, but really innovation that makes impact is often just piecing together things that we already know, but we don't always have the headspace to implement.
Thank you, Farzana, for saying that, because as a regulator, CQC is really committed to ensuring that people receive safe, effective, this compassionate, high quality care. And like you said, it's putting all these pieces together that makes it innovative and ensuring it's safe. And we do acknowledge that there are still inequalities in healthcare across different areas of the country and amongst different populations, like you mentioned in your area around cervical screening and making sure you reduce the stigma around it. And that's why we think, as a regulator, we have to always ensure that people receive the safe, effective, compassionate care, but taking into account their local population needs and what that practice is doing for that population. And we found that these GP practices tend to be in areas of high deprivation, often having large health inequalities. And that's why they're going that extra mile to make sure they do these innovative things for their own population. And we have also noticed that reducing these health inequalities can occur over months and not always reflected as immediate improvement in health outcomes. And we really want to emphasize it's not all about regulating targets, but also promoting this innovation with a bigger picture at the end of regulating healthcare with the aim of reducing health inequalities and benefiting the population as we go on in general.
It's so helpful to hear you say that, Devina, because one of, I think, the frustrations has been for many providers and myself is that we do often look at the end picture target. So if we take the cervical cytology, for example, is 80%, but as you say, it's how you got there. So my friend in Loughton is getting there in a very different way to how we are getting there. And yeah, for us to increase our smear targets from 50% to 74% took 2 years. It took 2 years, and now though that behavior has embedded both within the practice and also our patients, so they know that actually, you know what, they'll get a call, then they'll get another call, then they'll get another call, so they know that, and it does change behavior, so it does make it easier then to tackle that health inequality, and absolutely, I mean, this is so important. We know, don't we, that the Marmot 20 report came out, and that if you are a woman living in an area of high deprivation, you are actually living 10 years less than you were before. If we just think about that, obviously being a woman living in a deprived area, it's shocking to think that, you know, I live in one of the most iconic cities in the world. I live in Newham, and actually people are dying, women are dying 10 years younger. So it's something that I think we all have a responsibility to tackle.
Farzana and Devina, thank you very much. And Farzana, that was a great example of innovation that you gave there. Devina and Annabelle, has this project so far uncovered any other good examples of innovation that you can share with us?
Yeah, I've been an inspector with the CQC for coming up to 10 years now. And one of the things that I absolutely love about the job is hearing what practices are doing to meet the needs of their patients. I've had the pleasure of working with some truly inspirational practices. So this was pre-pandemic. One of the practices that I'm thinking of worked with patients who'd been relocated from their homes to live in houses of multiple occupation on a large scale, and they were away from their support networks. Their children were walking miles to school every day with only a disused car park to play in. But this practice, it was fabulous. They were so committed. They worked with public health teams to understand the risks and health needs of their patients so that they could provide truly exceptional joined up care. But the issue that I had as an inspector and we have as a regulator is, how do you measure that? How do you measure that innovation? Because that's having an impact on people's lives. But it's not, as Farzana discussed before, that's not going to show up tomorrow. That's not going to show up in tomorrow's QOF figures or public health data, but it's making a real difference. So as we move forward with this project, what we're looking at is how to capture that innovation and how to not necessarily measure the innovation, but capture it. We need to be looking at people's experiences rather than just sticking to traditional data sources. And as Farzana said, it takes time for those kinds of innovations to be measurable at all. It might never translate into a traditional data source. So although this project's in its early stages, the vision is that we could capture that innovation when it starts. We want to be able to say to practices, this is an innovative approach to tackle health inequalities, and celebrate it at the inception. And as the innovation becomes embedded into routine practice, we need to be looking beyond those numbers. We need to listen to what people are telling us. We as an organisation need to be dynamic at understanding what improvement is.
I'm really interested to hear you say that, Annabelle, and really pleased actually, because it's difficult, isn't it? Because obviously, as regulators, of course, you need to give the public and yourselves assurance that practices are safe. As Devina said, you know, that's one of the key, one of the clues, isn't it? One of the indicators. But as we move, and COVID and the pandemic has shown us, the vaccine rollout has shown us that actually general practice doesn't work in isolation. We're part of a system. So it was interesting hearing you talk about those people who had been, you know, relocated, and actually what the practice was doing. Because yes, that's not going to come out in your 80% gained for your diabetes targets. So we measure things that are important, but there are also things that we're not measuring, and perhaps what we might call those process measures rather than those outcome measures. And it reminds me of, I've given an example of a very practice-based innovation that we did, if you want to call it an innovation, to increase our cervical smear targets. I probably at the time wouldn't have thought of that as an innovation, but thinking about it, it is. A different project that we're doing now that's more system-based is we found, sadly, that many of our young children in Newham get stabbed to death. It's a problem across the country, very much a problem in London, but I have had 3 teenagers, which is quite a lot for a list of only 5,000 patients, stabbed to death just in the past few years. And my last patient, it's in public domain, it was on the BBC just 2 Octobers ago. Baptista was stabbed to death at 3:30 in the afternoon on his way home from school, 2 minutes from where I live. And I just thought to myself, what are we doing for these people? Because they're not on a cough register, we wouldn't know about them, but actually kids are dying. These are people who have not lived a life yet. So I'm fortunate to be part of a national health inequalities project called the Complete Care Communities. And London has 3 sites. There's 20-something sites over the country, and it's expanding. And we have chosen, as a primary care network, not a practice, as a primary care network of 7 practices, I'm the clinical director for one of our primary care networks, to look at this group of young people, 11 to 16-year-olds, to identify them and think, can we identify any risk factors? Is there anything we can think of? And we've just come up together as a group of practices to think about perhaps, you know, are they going to school, homeless, just a couple of risk factors. But the great thing about that, and I was interested listening to Annabelle, is that we've been working with schools, we've been working with public health, we've been working with some young people, and I've never done that before, 20 years as a GP. And not only is it really exciting, I think that it's definitely going to improve population health. I'm not sure how you regulate something like that, but I'm sure there's a way. And these are the things that are, I think, you know, what I'd call like big scale innovation, but not doing it on our own. And I think while general practices are great, we're small, agile organisations. In that sense, we're very different to hospitals and community trusts. We can implement change very quickly, but there's a lot that we can't do on our own, and working collaboratively. And you know, when we saw the NHS long-term plan come out in 2019 and even today's integrated care systems coming in, it is about collaboration, because we know that our patients, the people we serve, need more than just one service. They don't mind what service it is. We need a joined up service. So it's great to hear your example, and I think I'd love to see and be part of that sort of innovation more, where we've got our schools, our public health, our voluntary sectors. So we're more than halfway through our project pilot. We'll keep you posted on how that's going with our trying to reduce knife crime.
Well, that's an excellent project, Farzana. It's going to have a real impact for your community. And I'm glad you discussed collaboration, because what we've done so far in the field work for this project is obtain case studies from GP practices around all areas all regions of England, and we've seen that a lot of the innovative practice has impacted not only at place level but at systems level. And we've had examples of these innovative projects where they're working with their local health authorities, or they're working with a group of GP practices or their primary care networks. So we've collected over 80 case studies actually, revealing this innovative practice. So we're working with the Yorkshire and Humber Academic Health Science Network, so they are collaborating partners for this project. And we've been liaising with the external stakeholders such as NHS England and Improvement Health Inequalities team. And we're going to use all of this learning from these case studies. So we've been interviewing those practices, we've held roundtable events, some focus groups with inspectors, and also the patient voice, making sure we incorporate that into what we develop into helping GP providers evidence their innovation. So that's where we've got to the project so far.
And I think that in our fieldwork, what came out was that practices don't always know if what they're doing is innovative. So we need to find a way of capturing that innovation. And as a regulator, we need to review how, going back to the point about measuring impact. We need to find out, what the impacts are on communities, and go beyond traditional feedback sources such as GP patient survey, and actually listen to what people are telling us. Because once we as a regulator can capture that innovation, then it's going to be better shared to encourage improvement across practices and systems. So it can only be a positive thing.
That's such an important point, isn't it, Annabelle, where practices don't always know if they're doing something innovative. So if you had asked me 5-6 years ago with the cytology, is that innovative? I would say, well, no, I don't think so. This is what we're supposed to be doing. We're supposed to be increasing our smear. So it's only when we put it all together, we thought actually we're doing something a bit different to others, but others could also do that. It's not once you've kind of got your recipe, if you like, you could actually pick that up and share that and hope to implement it in another practice.
Yeah, absolutely, Farzana. And that's something. Bear in mind, this project's only, it's a quick project, but that's something that we want to be able to capture. We want to be able to not just capture but support practices to evidence their innovation. Because if practices aren't aware that what they're doing is innovative, then chances are then they're going to struggle, or they could do with some support or help to show the regulators what they're doing. Because quite often practices are doing really innovative things, but they struggle to evidence it through our current regulatory systems. There are ways currently where we can capture innovation, but I think that it definitely needs some further improvement. It definitely needs this project to make sure that practices are supported to evidence their innovation, so that can be shared.
Thank you, everyone. Some really great points there, and some really great examples of innovation. And it's clear that innovation is important in tackling health inequalities. Devina, what outcomes are we hoping that this project will achieve? And the recognition of innovation, is that a key outcome for the project?
Thanks, David. So as Annabelle and Farzana alluded to, these innovative approaches can have significant benefits for populations that may be going unrecognised, with sometimes potentially a negative impact on ratings. And we don't want GPs having this perception that innovative solutions are not valued. So we really want to change this. And this project is in line with the government's priorities as well in relation to encouraging innovation in primary care. And we also want to try and improve GP practices' experience of and confidence in regulation. So we've already seen remarkable examples in the case studies we've collected to date. And really what we aim to achieve in this project is helping these practices evidence their innovation so it's recognised within the regulatory process. And therefore we'll foster this supportive regulatory environment for services where they feel able to try these new approaches to care to reduce health inequalities. So that's our main overall aim.
Farzana, what support do general practices need to be innovative? and to tackle health inequalities. And you mentioned a bit earlier about working collaboratively. Do you see that as being a big part of what will aid general practices?
I think that is a big part. I think the first thing they need, though, is the time and the headspace. I think that, or I would go as far as to make the claim that all general practice at the moment would say we're going around the hamster wheel and there is no time. I don't know if you've seen that picture where there's two cavemen walking with something really heavy and someone's trying to give them a wheel and they say, no thanks, we're too busy. And it feels like general practice is a bit like that. We can't think of more innovative ways or smarter ways to work that would actually help the workforce as well, because we're just so busy. So I think some intentional time and headspace, which sadly is not given to general practice and wasn't given before the pandemic. And I think until that time for innovation is valued, I don't think we're going to move too far forward. I think some of us who are crazy and absolutely love this work will do it, but I think the majority won't. So I think given the time and the headspace, I think there'll be a lot more innovation. I think there is something that, if I may be so bold as well, that the GP provider relationship with the regulator at the moment is still they're coming to mark my homework, which, you know, how we change that issue, because it's clear that that's not what it's about. And I have had a CQC visit myself as a registered provider. It certainly wasn't. It didn't feel like there was just homework being marked. But I think that is something that then puts GP providers, maybe puts them on the defensive a little bit, so it's harder to share if you don't know that you're doing something innovative. So I think those two are probably the biggest things that need to be addressed, giving GPs and their teams headspace to actually think about doing something differently, and also thinking about how we view our regulators differently. Of course, there's a job to do, it's about regulation, but it isn't all about having your homework marked and having those red crosses. There's some nice green ticks as well.
Thank you, Farzana. And finally, Devina, what are the next steps for this project?
Thanks, David. And our next steps is basically learning from all these case studies, learning from the interviews we've undertaken, the roundtable events, the focus groups, and applying this to create something where we can help the providers evidence their innovation. Because at the end of the day, we feel better regulatory recognition and the sharing of this best practice could really pave the way for exciting developments in our primary care sector, bringing benefits to both practice teams and people using the services.
Thank you, Devina. And that's all the time we have for today. I would like to thank my guests, Dr. Devina Maru, Annabelle Stigwood, and Dr. Farzana Hussain. You can keep up to date with the CQC Regulators Pioneers Fund project at cqc.citizenlab.co. Just follow the link in the podcast description. Until next time, thank you for listening.